Hello, I'm Dr. Ken Landau. Thanks for joining us. We're going to be concluding our discussion of Gastro-Esophageal Reflux Disease, GERD, acid reflux, heartburn. I've already said it's a common condition. In fact, somewhere around 60 million people on a monthly basis, 15 million people on a daily basis. We know that it's associated with acid reflux from the stomach into the esophagus, or maybe it's not. We know that it's probably not a disorder of increased amount of acid, and as a matter of fact, people with this condition don't make any more acid than people without the condition, and we know that a lot of people have reflux. In fact, everybody has reflux at some point in time of the contents of the stomach into the esophagus, but the overwhelming majority of people don't have any symptoms, and even people with gastroesophageal reflux disease have reflux without symptoms. In the overwhelming majority of cases, we know that most people don't even have erosions inside the esophagus, so that if we look with an endoscope, if we look at the esophagus, we don't see anything wrong in the overwhelming majority of people, especially in women. We know in men there's more of a tendency to develop some of the erosions, and erosions seem to be associated with some of the complications of GERD. So they're associated with, first you get the erosion, then theoretically you could get a stricture, some scarring, some narrowing, so that big pieces of food can't pass from the esophagus into the stomach. And then we know that that group is associated with an increased incidence of something called Barrett's esophagus that we talked about at length. And Barrett's esophagus is thought to be, at least in some people, a forerunner to adenocarcinoma, cancer of the esophagus. So that's very important. And then we know one of the complications of gastroesophageal reflux is indeed a higher incidence of esophageal cancer. But the question is, if you have just the non-erosive symptoms, do they necessarily progress from non-erosive to erosive, from erosive to strictures and to Barrett's and to the cancer? Not necessarily the case at all. And as a matter of fact, we think if you start off with non-erosive symptoms, you're probably going to have non-erosive symptoms forever. It's not going to be progressive. If you have erosive symptoms, again, they're going to stay erosive. They're not going to go on in the overwhelming majority of people. It's not a progressive disorder. Well, the question is, are the symptoms uniform? And the answer is no. You get heartburn, but heartburn in some people is associated with little mild indigestion. Other people, it's a major symptom that keeps them awake at night, causes a decrease in the quality of life. We know that sometimes the condition can be associated with extra-esophageal manifestations. We know that some people who have heartburn also seem to have a higher incidence of asthma, recurrent ear infections, pharyngitis, laryngitis, sinus infections. Are they associated? Well, statistically they're associated, but we know that if you have the gastroesophageal reflux disorder and we treat it with success, those symptoms that are not associated with the esophagus don't seem to go away. If a person has symptoms, do we have to evaluate them medically, or do we just begin treatment? Well, for the overwhelming majority of people who have symptoms, no medical consultation is required or necessary or appropriate or going to end up in a good thing. So the overwhelming majority of people who have acid reflux just take care of themselves with over-the-counter antacids, Rolaids, or Tums, or Mylanta, or something of that nature. And some people can go and take other kind of medicines. You can go and take the histamine receptor blockers, medicines like Tagamet or Pepcid, or for other people, you can get those once prescription medicines like omeprazole or Prilosec. You can get them now without a prescription. But for some people, we need to go and evaluate them medically. So people who have persistent symptoms while they're on therapy, they don't seem to get better, those people need evaluation. And perhaps people who have more frequent symptoms or people who have regurgitation of food, those people might require some kind of evaluation. And in those people who are considering surgery, well, before you have surgery, you ought to have some sort of medical intervention. And then we call people who have what are known as alarm symptoms. We call those people should have medical evaluation. So people who have dysphagia, when they can't swallow the food seems to stick. Well, those people might have a stricture or a ring, or they might have a malignancy, or they might have a motility disorder. So those people need some kind of evaluation. And people who have weight loss, they need evaluation. People who have some bleeding, people who have a mass that can be detected, all of those need some kind of evaluation. What are the other diseases that can cause this kind of problem? Well, these kind of symptoms can be associated with coronary artery disease, gallbladder disease, cancer of the esophagus, cancer of the stomach, peptic ulcer disease, infection, or maybe you took a pill that was inappropriate to be taken. Maybe it caused some sort of damage. Maybe you consumed some lye by accident. Maybe you have abnormal junction of the esophagus and the stomach. All of those might require some sort of evaluation to decide what the underlying condition is. There's also another condition that's frequently mistaken for gastro-esophageal reflux disease. It's just an allergy. And we think it's some kind of a food allergy. It's called Eosinophilic Esophagitis. Same kind of symptoms. Different kind of therapy, however, because it's an allergy to a food. So you have to go and change your food. Some people think that what we should do as far as testing is concerned with this kind of condition is simply begin therapy. Give you a proton pump inhibitor medicine like omeprazole, Prilosec. And if we give you one of those medicines and you seem to get better in a short course of therapy, so within 4 to 8 weeks, your symptoms are at least 50% improved, then we say, well, you probably are suffering from heartburn. But you might not, because you might have had an ulcer, might be a placebo effect, or you might have what we call a functional disorder where you have symptoms, but you don't really have the disease. Well, how do we evaluate people? What kind of tests do we do? Well, the one that's most popular nowadays is endoscopy, where we put a tube down and we actually look into the esophagus, but it's not a very good test. And the reason it's not a very good test is the overwhelming majority of people who have gastro-esophageal reflux disorder have what we call non-erosive disease. So we look down there and we don't see anything that's abnormal. But some people say, well, what we should do is we should screen maybe once in a lifetime for that Barrett's esophagus we talked about. And Barrett's esophagus is a condition that might degenerate into cancer. People argue about that, and probably it's not a good idea to do screening for that because the likelihood of the disease is relatively restricted and the progression is not very good. It's not a common sort of a progression, so that we know that only about 0.1 to 0.3%, so not even 1%, not even 0.5% of the people per year are going to go on to develop cancer. So that isn't a good reason to screen. Well, biopsy might be appropriate in some people where the symptoms are abnormal or they're atypical. We might find that a person has this eosinophilic esophagitis that I mentioned before, where you have a lot of eosinophils, a lot of particular kind of white blood cell in the esophagus, and that tends to be associated with allergies. Tend to have a lot of those cells. And then we know that there are other ways to evaluate people. So we don't have to do just the endoscopy or just the biopsy. Maybe we do some reflux monitoring. We can do that on an ambulatory basis. It's kind of expensive, but we can measure what the pH is of the esophagus at different times. We can do that in any number of ways. Some people, we do a barium swallow where there's a question about a stricture or something of that nature, or we're evaluating peptic ulcer disease. The barium swallow done for a long time. It's sort of fallen out of favor lately, and there are some impedance tests that we can do to find out if we're talking about an acid that's less than a pH of 4, maybe between 4 and 7, or maybe we're talking about an alkaline reflux, and then we can do some manometry, and the manometry can give us an idea about what's happening in the esophagus and do we have propulsive movements. All of those are appropriate tests for a very select number of people, for a very small group of people. But then what we should do is we should consider therapy. Now, if you have gastroesophageal reflux disorder, if you have the disease, if you have this GERD, we've said that there's some kind of an abnormality. We don't know exactly what the abnormality is. Most people assume it's too much acid. Well, it isn't. Most people assume it's an abnormal lower esophageal sphincter, that area in between the esophagus and the stomach that normally is closed, but every once in a while relaxes when it's not supposed to relax, that allows something to get from the stomach back into the esophagus. And those transient lower esophageal sphincter relaxations seem to have a lot to do with it, and so too does the acid pocket in the stomach, and so too does a hiatal hernia. All of that has to do with this condition. And forgetting all about that, what we do is we just go to treatment. So how are we going to treat the condition? Well, in the past, our goal was principally to heal the erosions in the mucous membrane. And that was what we did, and it was thought that it was important because the condition would go on. Now we know that people can get these erosions, and the erosions have nothing to do with the severity. But if we treat the erosion, and if we prevent the erosion from going on, maybe we can prevent some of the strictures or the ulcers or the bleeding. Maybe we can prevent the Barrett's esophagus. Maybe we can do something that improves the quality of life. But you have to realize that in a lot of people who have heartburn, all you have to do is swallow. All you have to do is maybe alter your diet if there's some precipitating food. And maybe you don't need any kind of therapy, medical therapy at all, in spite of the fact that we have a very heavy concentration in the media, on the television, the radio, the print ad, of enticements to go and use some kind of medication. We know that there are a lot of direct-to-consumer ads telling you, you got to get the purple pill. You have to go get Nexium. And as a matter of fact, Nexium in 2012 did $6 billion, $6 billion with a B, dollars. And overall, the proton pump inhibitors did about a little shy of $10 billion in business. Let me tell you something, the placebo response is somewhere around 20%. So an awful lot of people taking medicines that they probably don't need. And you have to remember that a significant number of people who have symptoms of acid reflux don't have any acid reflux. That's not the problem. So the treatment, if you have symptoms every once in a while, do we treat you every once in a while, or we get treatment on a regular basis? Well, for the overwhelming majority, if your symptoms are few and far between, well, intermittent symptoms, periodic treatment would be adequate. The number of people who need continuous or permanent treatment is relatively few, relatively small, but some people going to develop the symptoms forever. And you have to realize this is a chronic condition. It isn't just usually temporary. So what can we do? Well, the advice has been going on forever that foods are associated, and in a significant number of people, you can identify a certain food that will precipitate symptoms. However, when you go to see the doctor and the doctor makes the diagnosis, one of the things that you're going to get is a laundry list of foods to avoid. But we know that the specific instructions are not appropriate to all patients, because the overwhelming majority of people who have symptoms, maybe the symptom is going to be triggered by 1 or 2 or 3 or 4 foods or food groups, so avoid those. But you don't have to avoid everything. Just avoid the foods that are going to be associated with precipitation of the symptoms. Now, it's probably a good idea if you suffer from gastro-esophageal reflux disease, and especially if you suffer from nocturnal symptoms, don't lie down for a couple hours after you eat. And as far as foods are concerned, what about spicy foods? What about garlic? What about onions? What about fried foods? What about greasy foods? What about chocolate and caffeine, or citrus and tomato? What about carbonated beverages, or peppermint or spearmint or regular mint? Or what about alcohol? We have to realize that the overwhelming majority of people who have gastroesophageal reflux disorder probably don't have anything that would make them avoid those particular foods. Maybe 1 or 2 or 3. That's fine. Avoid those foods that seem to precipitate your symptoms. And as a matter of fact, in spite of the exhortations to avoid them, we know that they don't seem to have any effect on the lower esophageal sphincter pressure. So we know that drinking alcohol, having fatty foods or citrus, inherently there's nothing wrong with them. Now, certain medicines that you might be given, prescription medicines, might make the condition worse. So if you're taking a calcium blocker, that might not be appropriate if your symptoms are worsened after you take the calcium blocker, or maybe nitroglycerin, or if you have asthma, some of the theophylline products, or if you're depressed, maybe taking some of the drugs like Pamelar or dizipramine maybe worsen the symptom. And we know that in many people, the bisphosphonates can cause lots of problems. Those are the drugs that we use to help maintain the bone. Well, we also know that men who have some prostate disorders are going to take Flomax and drugs like that. They can relax the esophagus and seem to increase the incidence of symptoms. And so too can some of those non-steroidal anti-inflammatory drugs that are so popular. Drugs in the aspirin, ibuprofen, naproxen family can cause problems. Now, one of the routinely given pieces of advice, is to elevate the head of your bed. That's kind of goofy. If you have nocturnal symptoms and if you elevate the head of the bed, it might do something, but certainly it's not appropriate for the majority of people. A lot of people think that what you can do instead of elevating the head of the bed is just sleep with 2 or 3 pillows. Elevate your head. Well, actually, that can make matters worse, because if you elevate your head and you don't elevate the entire bed, then what you might be doing is you might increase the pressure inside your abdomen. And remember, we said that abdominal pressure, because you're bent over a little bit, might increase the symptomatology. So if you find that you develop frequent symptoms at night, yeah, consider elevating the head of your bed. But if it doesn't seem to reduce the symptoms, then hey, it's not for you. We also know that some people can increase their dietary fiber, and that seems to be associated with a reduction in symptoms. In some people, we know that it's very sensible to stop smoking, because we know that cigarettes seem to be associated with some sort of an abnormality of the lower esophageal sphincter and be associated with symptoms of gastroesophageal reflux. And we know that in those people who perform strenuous exercise, the exercise can either increase or decrease the symptoms depending on how much pressure you have in your belly. Now, we also know that weight control is probably pretty important. We know that there's a direct parallel between how much you weigh, especially if the fat is associated with your abdomen. So if you have a big waist or a big waist-hip circumference, big waist-hip ratio, you're more at risk than if you are just heavy and the fat is diffuse in its origin. We know that if you look at your body mass index, and if you can lower it by, say, 3.5 points, you can probably reduce the symptoms by about 40%. So that's probably a good idea. And it's a good idea if you're fat anyway to lose some weight. Well, weight loss surgery. A lot of people going to have some weight loss surgery because we said that gastroesophageal reflux disease is associated with being too fat. And one of the ways, if you're too fat, to get rid of the fat relatively easily is to go and have some sort of a procedure. But actually, the procedures may help or may not help. So for instance, you have the gastric band, that's associated with a marked reduction of the symptoms. So that's good. On the other hand, if you have a gastric sleeve, that's associated with a dramatic increase in the number of symptoms. So you can take the incidence of esophageal erosions, and they go from 18% up to about 50%. On the other hand, if you have the gastric bypass, well, the gastric bypass seems to be the best of all of the treatments. Now, question is, if you have gastroesophageal reflux disorder and you want to begin therapy, do you start off with massive therapy, what we call a step-down therapy? We start with lots and lots of therapy, throw in every class of medicines we have, and then slowly taper you off? Or do we start off and do the step-up therapy, start with a little bit of therapy, and then if that doesn't work, add something to it, and if that doesn't work, add something more to it? Well, it would seem that the step-up therapy is the most appropriate, and probably for those people who have relatively infrequent, not frequent, problems, antacids are quite adequate. So the popular antacids you go and get at the grocery store or the drugstore, these you can take. They work very quickly. You can take them whenever you need them. You do it for symptoms that aren't any more common than maybe once a week, once every other week. The medicines last for a very short period of time, couple hours. They neutralize some of the acid. These are the drugs like Maalox and Mylanta and Tums and Rolaids and alginic acid and the bicarbonates, and they all seem to work, relatively well. Gaviscon, in particular, seems to abolish the acid pocket. So you take that medicine, and the acid sitting on top of the food that's in your stomach, well, that seems to be dramatically reduced. It seems to be absorbed, and this medicine seems to float in the proximal stomach and seems to do a pretty good job. If those medicines don't work, then it might be appropriate to consider one of the drugs that we know as a histamine 2 receptor antagonist. Now, it's important to realize antihistamines. These are all antihistamines. And the typical antihistamine works if you have itchy skin, if you have some sort of an allergy, you go and take Benadryl or medicine like that. That's one class. That's what we call the H1 antihistamines. Well, these are H2 antihistamines. They work a little bit different. They work in the area of the gut. You take them on demand, and if you happen to have erosive esophagitis, and it's very mild, well, they'll probably work in 80% of the cases. On the other hand, if you have erosive esophagitis and it's a little more advanced, it's a little more aggressive, then it probably is only going to work, these drugs are only going to work maybe 30, 40, 50% of the time. And as a matter of fact, the earlier drugs like Tagamet, interfered with a variety of other medicines that you might be taking. On the other hand, the newer drugs in the family, the Pepcid, the Acid, those kind of drugs, may not. So what are the H2 receptor antagonists? Those are the drugs that are frequently available without a prescription. They work just fine. There isn't any reason to progress to a prescription drug if these medicines seem to work. If your symptoms are relatively mild, you can take the Tagamet or the Zantac or the Pepcid or the Acid, and they do perfectly okay. Your body sort of gets used to them after you've been taking them for about 2 weeks, but that doesn't alter the symptom control, so they're perfectly okay. The way they work is they prevent the activation of the histamine receptor on the cell in the stomach that makes the acid. That's very important. Let's go over that again. They work on what's known as the basolateral membrane of the acid-producing cell in the stomach that's called the parietal cell. They hook up with the histamine receptor and they block it from being further activated. It's very important to realize that because the H2 antagonists, the Tagamet, the Pepcid, the Acid, the Zantac, they are going to interfere with the ability of the proton pump inhibitors to work. So if you happen to take one of these drugs, the Tagamet, the Pepcid, the Acid, the Zantac, and you want to take Nexium or you want to take a drug in that family, they're going to prevent each other from working appropriately. So you can't combine those two drugs. Now, we'll tell you about an exception in just a moment, but that's a minimal exception. So if you're going to take one of these antihistamines, or if you're going to take one of these H2 blockers, as we call them, you realize that you're probably going to have to take them on a relatively frequent basis, and you have to take them for a couple weeks in order to improve the symptoms and keep the symptoms away, assuming that you don't have chronic problems. And you're probably going to have to take them on a daily basis. Now, in 1989, the first of the proton pump inhibitors came online. And the proton pump inhibitors, these are the drugs like Nexium. They are very potent in reducing the production of acid and allowing healing of erosions. Now, if you just have the regular symptoms, there's a question about whether they're going to be any better than anything else. But the question is, what did they do? Well, they changed the entire field. Prior to 1989, a lot of people were having surgical procedures, what we call fundoplication. Fundoplication, where they wrap the stomach around the esophagus, and that helps prevent the acid reflux. You have to realize that the proton pump inhibitors are very potent drugs, and they reduce the need for surgery. The proton pump inhibitors, the drugs like Nexium, are more potent, no question about it, than drugs like Tagamet. And overall, we know that just in 2012, there were probably more than 125 million prescriptions written for these particular drugs, the proton pump inhibitors. Now, they were treatments for both peptic ulcer and for the gastro-esophageal reflux disorder, but it's an extremely popular class of drugs, and the drugs include Prilosec. When it first came on the market, it was called Losec, but Losec and Lasix, a diuretic, were too close together, so the Food and Drug Administration changed the name, changed it to Prilosec, and now we have to worry about Prilosec and Prozac being confused. So some issues, but remember, we're talking about Prilosec, that's available over the counter, omeprazole. And then, as the patent was expiring, the company brought out another drug, much more expensive, and it's called Nexium. And Nexium basically is the same thing, but there's a little chemical difference because the omeprazole contains a resistant form and a standardly metabolized form of the chemical omeprazole. And the Nexium just contains one of the enantiomers, and it contains it in a little higher concentration. Aside from that, the two drugs are equivalent. Cost is a major issue, and now they're putting the omeprazole with a little bit of bicarbonate. So you have another choice. Or you could take the Prevacid or the Protonex, or you could take the Acifex. Lots of different kind of medicines in this family. And the question is, are they all alike? And the answer is, yeah, they really are. Is there any significant difference between them? Well, if you listen to the ads, yes, indeed, there are major differences between them, but in practical terms, are there any differences between them? Nah, just any one of them. Probably the cheapest one is as good as the most expensive one. Now, if one of these drugs fails to improve the symptoms, you have to worry that maybe you have the wrong diagnosis. So that's a major issue. If you're taking one of the pills a day and it doesn't work, maybe you need to take two of the pills a day. And if you take two of the pills a day and you still have nocturnal symptoms, then you might consider taking a low dose. Let's repeat that. You might consider taking a low dose of one of those histamine receptor antagonists, the drugs like Tagamet. If you take a standard dose, you're going to inactivate the morning proton pump inhibitor. So remember, the proton pump inhibitors don't like the histamine receptor blockers. They don't like them because they have to have those cells in the stomach activated in order to get in and do their work. If you take a high dose of the histamine receptor antagonist, if you take a high dose of the Tagamet or the Pepcid or the Acid, and then you pop one of the proton pump inhibitors, you're going to inactivate it. You're going to prevent it from becoming activated. Very important. Now, if you have moderate to severe GERD, you probably should be taking at least one PPI a day. That's a proton pump inhibitor. They're not to be taken at bedtime. Lots of people say, look, my symptoms occur at night. I have this nocturnal GERD you're talking about. So why would I want to take a pill in the daytime if my symptoms are at night? Well, let me tell you, they don't work at night. They need to have an activated cell in your gut. And if you don't have the activated cell, not going to work. And taking the pill with food or at bedtime is inappropriate. And as a matter of fact, a significant number of people who have symptoms, who continue to have symptoms with GERD, symptoms of GERD, are taking their pills at the wrong time, and changing and taking your pills appropriately 30 minutes, 60 minutes before you eat seems to be appropriate. So take them 30 minutes to 60 minutes before breakfast, or if you don't eat breakfast, take them before lunch. Now, some people argue that that's not important, but it is important. It is important. And as a matter of fact, 70% of the family doctors and probably a quarter of the gastroenterologists don't give you the right advice regarding when to take the pills. So remember, you have to take the pills 30 to 60 minutes before a meal in order to get the best effect. And then you should not take it at the same time as you're taking an H2 receptor antagonist, one of those drugs like Pepcid, Tagamet, one of those. Now, it's important to realize if you take medicine for nocturnal symptoms, yes, you want to take a pill at night. You better not take the pill at night if you're taking the proton pump inhibitor. You can take it a half hour to an hour before breakfast, half hour to an hour before dinner, and then you can have a small dose of the H2 receptor antagonist at bedtime. Small dose, not a big dose. And whether it really does any good or not, people argue about it. Certainly not an FDA-approved usage of the drug. Well, if we're talking about the proton pump inhibitors, they're all, like I say, pretty much equally effective. The cost, however, can range from less than $20 a month to more than $400 a month. But the effects are basically the same. If you don't get better with one of the drugs, you could try taking a different drug, a different family member, but don't keep switching from one to another because they're all basically the same. Is the inhibition of acid ever complete? Nope. These drugs will not completely get rid of the stomach acid, but they'll reduce it to a level that tends not to cause any kind of problem. Now, not everybody responds to these medicines, and sometimes you don't respond to the medicine because you're not taking it at the right time. We already mentioned that, but sometimes you have a genetic abnormality of that proton pump, and it just doesn't work because the medicine can't get in and can't be activated. The medicine is a prodrug. It's not an active form. When you take the medicine, it has to be converted in the body from the inactive form to the active form. And sometimes your body just can't do that. And rarely, you can have a condition, maybe something known as the Zollinger-Ellison Syndrome, where you just make an awful lot of acid. You make an enormous amount of acid. And maybe that can't be completely taken care of. Now, that's more common in peptic ulcer disease than it is in gastroesophageal reflux, but it sometimes happens. And we also know that the likelihood of the proton pump inhibitors, the medicines like Nexium or Prevacid, the likelihood of them working is greatest if you have the erosive esophagitis or if you have a heartburn, and maybe if you have some of the regurgitation, but it certainly is much less likely to work as you get down to those other kind of symptoms that are sometimes associated, the chest pain, the laryngitis, the cough, the asthma. You know, one of the major reasons why these drugs are not effective? Not only do you take them at the wrong time, you don't take them. So about 40% of the people, 40% of the people who are taking the proton pump inhibitors aren't getting better, and probably 25 to 50% of those people who are taking the drugs, who say they're taking the drugs, who get the prescriptions or go to the drugstore and get the drugs, they just don't take them the right way. They just don't take them. They're not compliant. They don't take an appropriate number of pills. And when you take these pills, they do work for a fairly protracted period. They work for the longest period. They work much longer than the antacids, much longer than the histamine blockers. On the other hand, they don't work on contact. So it doesn't go to the stomach and work in the stomach. They have to get absorbed from the stomach. They have to get to the bloodstream. They come back in the blood to the stomach, and then they get to that gastric parietal cell. And that's how they work. Well, they work through a variety of specific processes inside the gut. And we know that they're superior to anything else that we have at the present time. We know that you have to take them for probably 4 or 5 days to get the maximum effect, but they probably are going to become effective in the 6 hours or so after you start taking the drug. They just won't be as effective as they will be over a period of days. And we know that with the acid suppression, that you're much more likely to have healing of those esophageal erosions. Patients are going to be satisfied. We're going to have reduction in the symptoms. And you have to take the drugs in order to heal for probably somewhere between 4 and 8 weeks. And then we ought to have, if you have an erosion, we ought to have somewhere between 90 and 95% of those erosions healed. But that doesn't mean your symptoms are going to go away necessarily. We'll probably find 30-40% of the people still symptomatic. Now, if you're still symptomatic, as I said, you could change from one drug to another in the class. Maybe you go from the Nexium to you switch over to the Proton. That would be okay. Maybe you increase the dose from 1 pill to 2. Maybe you add the H2 blocker that we talked about, a small dose just at bedtime. We know that a lot of people are going to have, even just taking 1 pill a day, you're going to have the nocturnal breakthrough. If you take the pills and you take the pills just at bedtime, well, it's only going to reduce your symptoms by about 9%, 10% of the time. It's not going to be very effective. If you take them at mealtime, it's going to reduce the symptoms maybe 15, 20%. That's not very effective. If you add the H2 blocker, the best that we can do is probably reduce your symptoms by about maybe 50%. Now, it's important to realize that once the symptoms have resolved after a month or 2 months, then the question is, what do we do? Well, if you stop the pills, remember, this is an ongoing problem. So chances are, if you stop the pills, you're going to get your symptoms again. So if you totally discontinue all therapy, probably within 10 days, 2 weeks, you got your symptoms back. So what do you have to do? Well, you could take the pills sort of on demand, or perhaps you could take a low dose for a long period of time. And periodically, you're going to have to increase the amount of drug that you take. Now, do the drugs have side effects? Sure. Everything has side effects. So they're changing the acid. Well, acid kills bacteria, so if you kill the acid or stop the acid from being produced, you're going to increase certain kind of bacteria in the gut. So you can have an increased amount of Salmonella or E. coli or Listeria or Vibrio or Campylobacter, a whole series of bacteria that you probably don't want too many in your gut. And you do have to be a little bit careful. You're going to decrease the amount of ionized calcium, because remember, calcium is going to require, for the most part, an acid balance in the gut in order to be absorbed. And if you don't absorb a lot of the calcium, well, then you have to worry, especially on a chronic basis. Are you going to do anything to your bone mineral density? Are you going to increase your incidence of fractures? And some of the reports show that people taking these proton pump inhibitors, the Nexium type drugs, if you take them for more than a year, you can increase the likelihood of developing hip fractures or wrist fractures or forearm fractures. But the increase is relatively mild, relatively small, and it's recommended that you don't need to get bone mass density taken on a regular basis, or even at all. You don't need to even take calcium supplements. Should you be screened for Helicobacter pylori? Nah, you don't really have to. Another problem is that B12 is absorbed with the acid, and you don't have the acid, so are you going to have a problem with B12 absorption? Yeah, some people do. And so, too, can you have a reduction in non-heme iron that's being absorbed? So these drugs are associated with some kind of potential problems. Perhaps most importantly, we find that if you don't have the acid, then you can get an overgrowth of a bacteria known as Clostridium difficile. That's the one associated with massive diarrhea, and that's a major problem. And also we know that people, if you don't have the acid that kills the bacteria, well, some of the bacteria then may be refluxed. If the bacteria are refluxed, then you might swallow them into your lungs, and then we know that community-acquired pneumonia is increased in incidence in people taking these drugs. And also we know that if you take these drugs, you're going to decrease the amount of magnesium that you're going to absorb, and if you decrease the amount of magnesium, you might get some muscle spasms or some irregular heartbeats or some seizures, and especially you have to worry if you're taking digoxin or if you're taking a diuretic. Now, we know the first generation drugs, the Prilosec, That can interfere a little bit with some of the drugs like Coumadin or the anti-anxiety drugs, or if you're taking the AIDS medicine. All of those are minimal impact. But we know that there was potential, especially with omeprazole, the first generation drugs, to interfere with the activity of Plavix. Now, if you're taking Plavix because you're using it as a blood thinner because you had a history of heart disease or stroke, you could increase your likelihood of problems. So you ought to talk to your doctor. While the FDA says there's a significant association, most people believe the association is modest or non-existent. However, it's something that you should talk with your doctor about. We also know that some people don't have the enzyme necessary to metabolize the proton pump inhibitors. We know it's relatively uncommon for whites and blacks not to have that enzyme, but Asians, about 1 in 5 people from Asia don't metabolize these drugs, so they stick around a lot longer in the system. Now, clinically, that means that they could take a smaller dose, but practically there's no significant problem associated with that. Well, if you don't want to take the medicine, say, I'm a naturalist, I don't want to take any drugs. Are there any herbs that might be effective? Yeah, they don't seem to work very well. Some people take licorice or slippery elm. Some people take chamomile or marshmallow. Marshmallow, the herb, not marshmallow, the sweet that you go to the store and get. Well, they might be a little bit helpful in some people, but the likelihood of significant long-term effect relatively small. So some people take melatonin, and melatonin, if you take it at bedtime, 2.5 milligrams, in some people it can cause increase in the lower esophageal sphincter pressure. That might be effective. And in some people, if they can't tolerate any of the other drugs, well, some of the medicines like baclofen that we use for certain neurologic disorders might be effective, and so too we have a series of prokinetic drugs, drugs that sort of speed the peristaltic waves from the upper gut to the lower gut. Those drugs might be somewhat effective. And then in some people, taking the selective serotonin reuptake inhibitors might be helpful, drugs like Prozac, or in other people, maybe there are some experimental drugs that seem to be effective. We won't go into them, but there are a variety of drugs on the horizon that might be helpful for some people. Then surgery. Is surgery effective? Well, many people prefer surgery because they don't want to take pills. They don't want to take pills on a regular basis. And they think that if they have surgery, then they can treat the condition, eradicate the condition so it doesn't progress. On the other hand, that's probably not the case. And even though you have the surgery, even though you have what we call fundoplication that's now done laparoscopically, chances are overwhelming you're going to have to continue taking the medicine. And as a matter of fact, if we look at the long-term outcome, we find that it isn't any different between the people who get surgical therapy versus those people who get medical therapy. Well, if you're considering surgical therapy, you have to realize that it has some complications. It might be good for non-compliant people. It might be good for people who are unable to take the proton pump inhibitors. It might be okay for people who have regurgitation. But the control of the symptoms isn't going to be any better than it is with medicine. And if you have the surgery, you have a much higher chance of having to have another surgery to correct the problem from the first surgery. And if we look at the people who follow them, say, for 7 years, not going to be any difference. Surgical therapy was started before the proton pump inhibitors, and we have a whole bunch of fancy names. We talk about Barrett's esophagus. Well, Barrett invented one of these fundoplication procedures where they take the stomach and wrap it either partially or fully around the esophagus so it can't get up into the chest. We have Nissen, who's the most popular procedure. Well, the side effects, they're less common if we do a partial than if we do a total fundoplication. But sometimes people who have the procedure actually have dysphagia. They can't swallow. They get a significant amount of flatulence. They have what's known as the gas bloat syndrome. In somewhere up to 1 in 5 people, they have problems with their bowel, and of course you have the potential for surgical mortality. Now they have a variety of other procedures that are being advertised heavily, and you have to wonder, what's the fascination? We have all these procedures that haven't really stood the test of time that are being promoted to the general public, and I would say that you should be extraordinarily cautious before you undergo any of them. And remember, even if you're going to consider some of the routine surgeries, it seems that the outcome in university centers or in what we call tertiary referral centers seems to be better than it is in some of the community facilities. So if you happen to be suffering from gastroesophageal reflux, hopefully, over the past 3 shows, you've learned something about the symptoms, something about the cause, and something about what you can reliably do to them. Don't be seduced by the ads on the television. Don't necessarily jump at what's considered a cure as far as a surgical therapy is concerned, because many of the people who opt for surgical therapy are going to find they have the surgery and they're still taking the pills. And remember, if you suffer from gastroesophageal reflux, strictly avoiding foods just because they're on a list somewhere doesn't necessarily gain you anything beneficial. So if you have any questions, let us know. Thanks for watching. I'm Dr. Ken Landau.